So much for joining us today. My name is Dr. Ino Efuanyeni. I am an OBGYN practicing in Maryland, USA. I'm also the president-elect of the Ghana Physicians and Surgeons Foundation of North America. We are bringing to you one of our monthly general public question and answer sessions with a team of expert panelists coming to talk to you today about mood disorders in pregnancy and beyond. This session is brought to you in collaboration with the Ghana Physicians and Surgeons Foundation of North America, the North America Ghana Nurses Foundation, the Ghanaian Pharmacists Association. And today we bring you Deborah Amajesi, Debbie, who is coming to us from Ghana. She's going to share her own experience with a mood disorder in pregnancy with us. Debbie is a 24-year-old lady who lives in Hawaii, loves to write poetry and loves singing and listening to music. Dr. Kankam is our board-certified psychiatrist, our specialist who will be talking to us today about mood disorders. Miss Anita Paddy is our licensed clinical health psychologist. She's an extremely active lady. She holds a master's in clinical health psychology and is very active in various activities. She's joining us all the way from Ghana. She is a secretary of Ghana Society of Behavioral Movement, the Ghana Society of Behavioral Medicine and Health, as well as with the Psychological Relief for Women International and a member of the Mental Health Advocacy in Ghana. We have Dr. Ama Ajimai. She is joining us from the USA. She's an OBGYN, a very good friend from GPSF, who went to Harvard Medical School. She did her residency in OBGYN at the Boston Medical Center. She was raised in Ghana, and she comes from a long line of actually women or members of family who work in OBGYN. Her mom is a midwife in Ghana. So we are very, very lucky to have her join us today to share her expertise. We also have Mrs. Gloria Esiamafusu, who is a nurse practicing in the United States. She has 10 years experience on mother-baby. She has various certifications, and she is also the very, very dynamic host of the Asitsna Pamu Nsem TV talk show. So join her sometime. Then we have Miss Caroline Martinson, who worked as a midwife in Ghana. And she's also a nurse practicing in the United States with various certifications. Thank you so much for joining us, Miss Caroline. And lastly, we have Miss Ikuya Mwakontfo, who's a clinical psychiatric pharmacist, also joining us from Ghana. So they're all gonna introduce themselves today, and then we'll start with questions from the general public.
Okay, thank you all. As she said, I'm Dr. Jemima Kankam, a proud product of Ghana Medical School. Did my residency in psychiatry in Maryland, University of Maryland in Baltimore. And next year we'll start the 4th decade of my psychiatric practice. And in that time, mental health has gone a long way in certain areas, but we're still struggling in some. Our science has actually refined illnesses, medications, and non-medication treatments. We have a lot of options, but what are options on effective treatment if people don't know that what they are experiencing could be symptoms of an illness to come? That's where we struggle in our field. And lack of awareness, we know about stigma, but even those who would have come in spite of the stigma don't know because of all the myths about what mental health is and is not. So unlike my colleagues, whenever I start, we have to start with what are we talking about? We all say mental health and mental health disorders, okay? So there isn't any, in 3 decades, there is not 1 week I don't see a new patient that I'm reminded that we still have a long way to go. So I'm starting by briefly, I've only been given a few minutes, briefly to talk about what are we talking about when we say mental health. The first thing is, it's not all about feelings. That is still the notion that it's about feelings. Mental health, it's actually our mental health system is one of the 10 systems, just like the cardiovascular and the respiratory that everybody knows about, okay? And all the systems are put there to serve a purpose. And our mental health system, arising from the brain, is there to make decisions. So actually, it's a decision-making system. And so I have this, this is my only slide, okay? So I want you to keep this image. Illness arises from the norm. In the same way, as a child, we start to have the knowledge, intelligence about identifying things, identifying experiences, okay? So this is a knife, this is a snake, this is ice cream. We start to identify and group the meaning of the things that we have facts and knowledge about. There are 4 groupings, and these stand for the groupings. These groupings that we categorize, these become like the lens. Just like we look through the lens of our eyes, they become the lens of our brain through which everything else for the rest of our lives, we perceive them. So this is positive. That gives us the courage to explore, to take a risk, calculated risk, to be hopeful. We have the pessimistic view with regrets and self-blame and not as hopeful. We have the fear, which gives us the catastrophic thinking. And then, I think I missed this. Okay, then we have the anger, the angry making one, which is, it's the perception of being challenged, either your integrity. So in fear, you will tend to stay away. In the anger, you are challenging, you are likely to go aggressively, either emotionally or physically. So these are the perceptions. And as we get older and go out in the world, we reshuffle and we can change, but by the time we are mature, by the time, you're no longer a minor, you have a set patterns. Now, what happens is we look through through these situations, and if we determine that it is sad making, we recruit thoughts that are sad making. Then it sends signal, feeling. That's just a one word. People use, I feel like, no, that's words. You feel sad, we feel it here, and it's also expressed physically. And there comes a big part of the problem. Some of the physical expression are internal, our sleep, our sweating, our palpitation, nobody can see that. And then the ones that can be seen outwardly. So these are the 4 normal, okay? These are the internal and external. Now, at the normal, all these systems are helping us. So our mental health system helps us with our well-being. It helps us adapt to situations. It helps us relate appropriately, and it helps us to use our intellectual function to be successful in society. I'm sure we all agree that being wise and being knowledgeable are not the same thing, because we can see people who have one and not the other. So this is the system. Now, when it goes wrong, when it's working right, they are working collaboratively. You see something, it's not all good or all bad. There's some good, some bad. It doesn't allow us to go too far out, and like an elastic, it brings us to the center. So so that's when, and then it's flexible enough that we can change. Just like we can change our muscle, go to the gym and change how we want our muscle to be. we can actually change this because it's flexible. Now, to work right, the thoughts, we have thousands of thoughts going through our mind every single day. And we can't all have that in our focus. So it allows only the ones that is needed. So whenever you hear mental health, please think thoughts, feelings, and actions. And when it breaks down in terms of a couple of things, which will be relevant to what we're talking about. Either instead of them working together, it becomes one or two are suppressed. So for example, today we're going to talk about depression. And depression is actually the pessimistic. So it's almost like these three are suppressed, and it's the pessimistic one that is rigidly seeing everything through that lens. One of the things that is also important is that these, when they go wrong, the difference between the norm and what constitutes illness is the duration, okay? The duration and the severity and how it impacts us. So each of these, you know, the sadness, everybody gets sad, but when it's all the time severe and it goes on long enough to interfere with our function, then we say you have a bout of depression. We don't treat bouts. You don't treat a bout of coughing. You find out what the illness is. So each of these bouts, you have to find out what illness, and to find out what the illness is, it depends on which of these bouts you have. So for example, somebody who has had a bout of depression, if they have never had these two bouts, excessive happy, excessive anger, then we call the illness major depressive disorder, which we loosely refer to as depression. The person who is also has had some of these bouts, the anger and the excessive happiness to the exclusion of the others, if you've ever had that combination,
yeah,
that bipolar disorder. So with this, keep it in mind. We'll probably come back and talk about it, but I'll stop here, and Debbie will share her story, and you can keep this in mind as to when she's sharing it. Thank you.
Thank you so much, Dr. Kankam. Thank you very much for speaking. Just to summarize, you definitely gave us a very good slide to go over the different kind of emotions that our mind leads us to. And so you showed us that our thoughts lead to our feelings, and depending on which system is dominant and what you have experienced, then you can either have excessive sadness or excessive one side being too excessive. And some of it can start from our childhood and all the things that we associate, like the emotions and the feelings and the different signals that we associate. So thank you so much for explaining this to us and how things can lead to depression. We'll go into it a little bit more later with the questions that come up. So if Deborah is here, Deborah is joining us all the way from Ghana. We know that it's so late in Ghana. If you could tell us your story, we would be so happy to hear it.
Whether to continue their medication, if they're starting something new. Pregnancy is a scary thing, realistically. We don't know, we have no control over what's happening inside of our bodies, even with the best team around us. So to answer any questions as best as we can, I answer from the medical or medication side to help ease those concerns and make it easier for any woman that's going through that journey, as well as family members to better support the women who are going through pregnancy or giving birth. So this evening, I'm just here to provide support, answer questions, to also learn from you, your experiences, or anyone else that may have questions with regards to medication and supporting their loved ones. So it's really an honor to be here this evening, and I thank you.
Thank you so much, Ms. Yamakutufo. We appreciate you. Thank you for highlighting Debbie's story, her courage, for sharing. I know that it's really nice when you're going through something and somebody actually tells you, I've been going through that too. You're right. It is very encouraging. And Dr. Yamakutufo will be here. If anybody has questions later on, the audience, we are definitely here to get your questions. If you want to share your experiences, if you want to share your expertise, we would love to hear from you. You can definitely do that either by writing in the message all or just message me privately. You can also raise your hand and we can let you speak if that's something that you're interested in. But if you have any questions about medications and what medications you can take when you're trying to get pregnant, when you get pregnant, after, when you're breastfeeding, Dr. Kwamwako is here to share her expertise with us. And she is joining us all the way from Ghana. Thank you so much. Ms. Caroline Martinson, you are next.
Yes. Hi, everyone. Caroline, as Dr. Aino already said, I've been a nurse for the past 22 years, and I had my general nursing and midwifery training at Kolibu Teaching Hospital in Accra, Ghana. I worked there for 9 years before relocating to the US, and I've been working now at a long-term care facility as an MDS coordinator. My experience as a midwife gives me knowledge about mood disorder in pregnancy and breastfeeding. I look forward to some good discussions this evening. Thank you.
And Ms. Martinson, you also had some experiences that stood out to you, right?
Yes.
A midwife about women who had mood disorders. Would you like to share them with us?
Yes, sure. So there was one lady that was discharged home after delivery. She had an episiotomy. We gave her, education to sit on lukewarm water. But when she went home, her grandmother told her to use hot water. And then she was also using some herbal remedy for Duchenne. So the suture, the episiotomy dehisced and became infected. So she had pelvic inflammatory disease. She was running high temperature and ended up having hallucinations. So she was brought back to the hospital. She was admitted. We had to treat her for postpartum psychosis because, she became wild, having all these delusional thoughts and hallucinations. So my advice to our mothers and grandmothers at home is to adhere to professional medical advice to prevent such an occurrence. Yeah, and also there was also two couples that the wife to have a baby boy, but she was rather expecting a girl, so the man neglected the lady, and she became depressed for that. So we also advising the men to give support, emotional support to the women, irrespective of the sex of the baby, because actually the sex of the baby is not being determined by the females, it's by the men. Yeah, so the lady actually became depressed, yeah, from that. So that's some of the advice.
Having a lot of pressure, having a lot of stress put on her ended up causing her to go into depression, into like one line thinking. And then in the other woman's case, she got an infection, she got cut, she was given instruction, she ended up using something else, she got an infection, and through the infection, she became psychotic. So that is something that we can touch on, obodam, yichano, obodam. So, onya infection, crew. She went crazy and she had to be treated. So we can talk about all of this throughout our show today, our talk Q&A, if people have any questions about that. Thank you so much for sharing, Ms. Martinson. Ms. Gloria, you are up.
Oh, hi, everyone. My name is Gloria Fosu, Mrs. Gloria Fosu. I have been a nurse for 21 years. I started in Ghana, did general nursing, moved over to the US. I worked with mother baby for 10 years. Have been with oncology, that's end of life, hospice, for another 4 years. I worked on mother baby floor for another 4 years, and I'm doing dialysis right now. And I'm also in school, having my master's in psychiatry mental health as a nurse practitioner. So in a few months, I'll be graduating. My topic for this evening is on stigmatization on mental health or mental illness. As we all know, I would say back home or in Africa, when you say somebody has a mental disorder or illness, it's like a big issue, both to the family, the workplace that the person works. If the person is in school, it's another case. The community, the society, or if the person is in church or any place that people are, like, it's a big blow. Stigmatization or stigma in mental health, we say, is a negative connotation that is applied to somebody who the person perceive has something that is not normal to, like, abnormal in the society. It's a negative thing that they label people with. We all talk about physical health, but we don't talk about mental health. As in Ghana, as I said, it's a big blow. Example, if you are going to marry, if there's a problem or there's a mental illness in the family, and you are going to marry from that family, the other or the opposite one will say you cannot marry that person from that family because the family has issue with mental health, and that is no. You cannot do that because mental health is part of the body, and as we all know, we can sort for treatment or management that will help the person come back to their normal being. And we say that in Africa, we say that once the person is sick with mental illness, they never get healed or they never recover. It's never true. You can get postpartum blues or postpartum depression. They recover, they come out of it, they come back to their normal life and work and be in the society and also become productive for the community. So we cannot put a stigma on people. And in this way, it prevents people from doing so many things in the society. They abuse them, they bully them, they send them. I've seen one person who was having depression, and I think the pastor or the chaplain said that the person is possessed or has been attacked by a spirit. So they have to send the person to Malfi. There's they have a camp that they have made, that they put people there who are going, like, they have mental illness. They send them there, instead of sending them for treatment, they send them to the camp and they abuse them, they flog them, they give them only water. They have to fast for days without food, without medication, nothing. And you can see that they have sore with the chain that they chain them, because they become so aggressive and fighting back and all that. They have sores on their legs where they have been chained with metals. It's like they are prisoners, chained to a tree or a wall, something going on. And imagine the person is a diabetic coupled with psychosis or mental illness. The person will become infected and finally die. So I urge all of us as professionals, as health professionals, as people in the society, as people helping or the family, that if you see something going on, don't send people or don't send the mental ill person to any spiritual place or a camp for prayer. No, this is not the time. It's time for them to seek for medical help instead of going to the camp for treatment. And also, they can come back to the community and work. We should know that they can come after treatment, they can come back and work. When they have calmed down and everything is okay, they can come and work. And they can seek help from groups. If they have support group, especially in Ghana, they have Ghana Mental Health Association. They have so many support groups. And with the stigma aspect, I can see that now it's no longer. When I was working in Ankafo, it was too much. Even pastors' wives, I've seen pastors' wives in this mental health centers. And when they come, they hide. The pastors, they are coming to visit their wives, but they hide themselves to come over to visit them because they don't want that stigma attached to their name. So they hide themselves, they remove their socket and everything, and come and visit their wives. So from this discussion, I'll urge everybody to be proactive, advocate on behalf of this mental ill patient, because they are one of us, they are part of us. And as we are growing, they are also growing. And if they need help, we are there. We have to advocate for them to seek help instead of discriminating them from maybe, oh, there's nothing to come out of them. Especially people who are autistic, there's nothing like coming out from them. No, they are very important. Over here in the US, they train them, they have rehabs, they have occupational workshops that they send them to, and they become so productive and help the community. Thank you. If you have any question, you can bring them out. Thank you.
Thank you so much. Thank you, Ms. Gloria. We appreciate you. Thank you for highlighting the importance of stigma. Or actually, so basically, some of the stories that you told us are telling us how stigma, if your family thinks, okay, you have a mental illness, and because you have a mental illness, we don't want anybody to know. So we will not let you even go and seek help. We will not let you seek medication, or maybe we won't even let somebody marry into that family. Then people are more likely to stay sick. People are more likely to not go to the right places to seek help. You know, there's a place for definitely religion and helping, but there's also a right way to help them. But it's also a medical condition and they need to get help from that. And then families also need to support. Families need to know about these conditions so that they can get people to the right places. So thank you so much for highlighting how stigma can affect this, you know. And we will bring some more questions to you, especially if anybody has any comments on stigma. Now we'll go to Miss Anita. Anita, are you there? Anita Paddy?
Yes, I'm here.
We can't hear you.
Hello.
Hello.
Yeah.
Can you speak up?
Okay. Do you hear me now?
We can't hear you very well. Anita Paddy?
She was having some power problems.
Oh, okay. All right. Anita was our psychologist.
Hello.
Hello, we can hear you now.
Okay. So I am Anita Paddy, a clinical health psychologist with interest in maternal health and well-being. And over the years, I've realized that as part of our antenatal care and postnatal care, we are to concentrate on all aspects of health, plus the mental health well-being. However, when we go into our antenatal care book, we see that screening is very limited to only a question: do you have mental illness? Now the question is, how many people even know they have mental health issues? And the answer is obviously a yes or a no. If I say a no, does it mean that I'm cleared of any and
Anita, I think you muted yourself on accident. Can you unmute, please?
Yeah, Anita, you're unmuted now.
as I was saying, does it mean that if you answer no to it, the question?
I think it's Anita's power.
Anita's having a little trouble, but she's basically trying to tell us a little bit about mental health screening and pregnancy in Ghana. And she was saying that there is not sufficient screening. There's only one question, whether you have a mental health diagnosis or whether you don't. And most people will likely say they don't, because they don't know what the mental health conditions are. So maybe if you're pregnant or post, then you're not going to know that you even have a mental illness. You might say no. Or even if you have it, you might want to hide it. So you say no, as opposed to a more thorough screening, something that is more routine. So that's something that she has done research on in Ghana, and would like to encourage us all to do more of. She wants to do research, and she wants to highlight this issue so that there is more screening of mental health conditions in Ghana. So now we've gone through all our panelists, and we can get to some of our questions. It's taking us quite a bit of time. I want to thank everybody who is on here, who came to join and support us today. I'm sorry?
Anita says she's here, and I think she's trying to talk.
Okay, go ahead, Anita.
Okay, Anita, please go ahead. We're listening.
I think there's some technical difficulty.
I think summarized everything I wanted to say. So basically, it's about. Yes.
Okay, thank you so much, Anita. So we'll be sending some questions to you about counseling and
more of screening, more of antenatal care.
Okay. All right, thank you. Do you want to share anything else, Anita?
That's okay.
Okay, thank you. Okay, thank you. If you have any questions when we bring any answers to some questions, we will send them your way as well later on. Okay, thank you so much. I just wanted to highlight some of the things that were being said. So Miss Olarunde actually said, Deborah, thank you so much for sharing your story. There were a lot of comments later on before about those people who were kind of bombing us, and we are sorry about that again. Miss Esther Apraku Bonzi also said, thank you so much for sharing. So we will go on. And if any of the audience have any questions or any comments or any stories that they want to share, we are here to hear it. Dr. Kankam, do you have anything to say about Debbie's story that she shared?
First, I want to say that Debbie is one of my many daughters in Ghana on a support group called Psychosocial Support Group. And it's amazing, how much I learn. There is book and learning what we need, what our patients need. And some of the questions, when she was pregnant, she was asking questions. And when she was breastfeeding, somebody had said, maybe you shouldn't be taking medication. And knowing what she had been through, she was asking. And that's why I actually pressed you to do this program. Now, a couple of things I want to share. So Debbie, thank you so much. I know it's not easy. And some of the highlighting some of what she said. The average onset of many of the mood illnesses is, the book says age 14. I can tell you that I see people in their 50s, 40s, they can go all the way to elementary school. So if she wrote a suicide note at the age of 12, she was already experiencing distress that then accumulated into a 12-year-old getting to, you know, those perceptions that I said. Now, all that she was going through was viewing life through helplessness and writing that she didn't want to live. Hopefully, in this day and age, you know, it's still happening. You know, people see, oh, 12-year-old, what do you know about life that you think you want to kill yourself? So people are not taken seriously. I don't know if you heard what happened. She was counseled and prayed for, and that was the end. It's not that parents don't care about their children. That's all they knew. You know, they did the best they could. So hopefully, if your child is talking about not wanting, please take it seriously. In the US, people see their pediatricians. In Ghana and elsewhere, go to any, you know, any health professionals, because this program is not just about just the lay world. It's us too to take it seriously. So from age 12 to 21, think about if she had any other diabetes, any other illness, age 12 to 21, untreated. In that time, it has become more severe and more, you know, becomes less resistant to treatment. So that's what I want to highlight in her story. When I met Deborah for the first time, she was in the university. And you didn't have to be a doctor to see someone who is so depressed, you could hardly talk, you know. And yet, this lady is as smart as anything. Thank goodness she struggled through and still graduated, you know. And during, you know, even while she was in treatment, we are reminding ourselves to talk about what happens, that you could get pregnant, because she talked about bipolar disorder. The other side of depression is the mania. And unfortunately, everywhere, because it is expressed in behavior forms, people get in trouble. In the US, there are many people in prison, young men and women who would never have been there if somebody had, you know, had detected that this was what was going on. So in mania, there is this inhibition, that, you know, the risk-taking behavior, as she, you know, graciously shared and became pregnant, you know. So I don't know, she was talking about what was discussed. Certainly we want to encourage people to to use protection. But really in that period, it is difficult for the brain to be careful. So that's the part I want to highlight. Also, the fact that it doesn't have to be psychiatrist. Anybody that you see female, part of the screening that Anita talked about, even in the US, the screening that all disciplines are forced to do are just screening for depression. What about the other side of it? That's like screening for low sugar when you don't screen for high sugar. So there are many elements of that we can talk about. And I hope some in the audience can speak to her story. If you know anybody, you know, share, ask questions. So again, thank you, Debbie. Really, thank you for this.
Dr. Kankam, thank you so much for shedding some more light on Debbie's story in terms of just how brave, again, she is to come forward and share her experiences with us. She told us how early it started. She told us some of the signs that she was showing. She was writing suicide notes. She was being promiscuous. She told us about the medication she was taking. And then she told us how she got pregnant. We do need to learn more from her. And she told us how her medications affected her when she was breastfeeding. And thankfully, well, and she is well. I would like to hear more from Debbie about how her pregnancy was. What was pregnancy like for you, Debbie?
Pregnancy? How was it like? I was doing my service, my national service here in Ghana, the Ghana Revenue Authority, and I was pregnant, and then I was bipolar. So I had to, I was married. So having to go to work with my belly bump showing and with people casting glances at me made me feel very uncomfortable, because even here in Ghana, when you are married and you are pregnant, a lot of people do look at you. And for you not to be married and then you being pregnant, it wasn't easy for me. And then sometimes I would, with me being bipolar, and pregnancy also comes with you being a bit angry most of the time for sometimes no reason, and I could get so angry and I could talk to my boss anyhow. I could talk to anybody anyhow. People I respect, all of a sudden, just comment here and there, and I could just get angry and talk to them anyhow. But they were very patient with me and could calm me down. Sometimes they get somebody who is close to me, who has a very positive influence on me, and who they know that if they talk to me, I'll be calm, and then this person talks to me and then I'm calm. Sometimes I can go to a place to eat, or I can go to a place for maybe an audit service for my national service and all that. And sometimes joining a long queue is uncomfortable for me, and having my colleagues look at me because well, I had sex and I got pregnant, so it's something that shouldn't have happened. They'll be looking at me and I get so uncomfortable. Sometimes I want to leave and then move away from there, but I just can't, because there's something that I have to do there. So being bipolar and getting pregnant, sometimes you feel uncomfortable because your emotions and everything is over, and most of the times, if you don't control yourself and you don't take your medication regularly, you realize that you behave in ways that is beyond your control. And some people even get committed. Some people are pregnant and they can't handle themselves well, and then they have to be hospitalized. And I was always praying and hoping that I wouldn't end up that way. I was always living in fear. So basically, that's how pregnancy was for me. Yeah.
Wow, thank you so much for sharing that again. You touched on a lot of important things. I'm glad that you came out of that successfully, and that overall things went well, even though your emotions were a little bit up and down. Living in fear, that's very interesting. Amma, can you share a little bit about how pregnancy, how the medications, or actually Dr. Ikuya, you guys can both talk about how medication, how people can titrate their medications when they are pregnant, if they have either depression or bipolar disorder. Sometimes, this one affects some other conditions in pregnancy, but can you shed a little bit of light on that? Amma, you can start, and then Ikuya, you can go.
Yeah, I was wondering who you wanted to start.
Both of you.
Again, thank you so much for sharing with us, Deborah. Your experiences in pregnancy, I think, even without your diagnosis, is will resonate a lot with women who've been pregnant, because at some point we all have these feelings. And then I think having the diagnosis in addition definitely compounds things. So from the perspective of your obstetrician who's taking care of you, if you have a diagnosis and you're planning to get pregnant, or you get pregnant while you're on these medications, Usually the first trimester, the first 12 weeks of your pregnancy, we want to be very careful about what you're taking, because that's when we have the most development growing and changing that's happening with your baby. That's when usually most of the effects, if there will be any bad effects, could happen with certain medications. So one thing your doctor will do with you is look at what medications you're taking and at what point in your pregnancy you are. And based on that, have a discussion with our pharmacy colleagues. And Dr. Ikea is going to talk some more about the specifics, but we will tell you what is our experience with these medications in pregnant moms. What would we recommend? What do we advise? But one of the things that I think it's very important to hold on to as a patient is that the only thing really that will guarantee the health and safety of your baby is having a healthy mother. And so even though there may be some small risks to the baby, what we would usually tell you is, this is what we know. This is what maybe could happen, but most of the time it won't. But what is more important is that you are okay, that you are healthy, that you are taking care of yourself, and taking care of yourself in every aspect, including your mental health. And so if being on medication is going to ensure that, then that's what we're going to do, and we'll support you through it. One of the things that we know is as your pregnancy progresses and you're more and more pregnant, the way in which you process the medications in your system changes. And so sometimes we might have to increase your dose because of that, so that you have an effective amount of the medicine in you. And it's not permanent. So after you're no longer pregnant and you don't have the, your baby inside of you, you might go down on the dose of that medication. And that's all something that we will help you and counsel you on. And our pharmacy colleagues are very, very helpful to us in helping to figure out that. And sometimes we have to do blood tests to see what is the level of the medication in your system to help us to get those, the effective level achieved.
Thank you, Amma. Ikea, can you speak a little bit on the medications that are used in pregnancy, especially with bipolar disorder, but also, is it safe if you are depressed, clinically depressed, or bipolar? Is it safe to take medications in pregnancy? Can you tell us a little bit about the classes or anything, just, for the general public?
Thank you very much. So for us, we look at, can you hear me? Am I unmuted? Yes. Okay.
Yes.
Yeah, so we do have different classes of medications that we use for mood disorders. I personally like to look at the individual medications, because sometimes when people hear certain names of classes, they feel like, oh, I don't have this, so I'm not going to take this. But it's just the way the medication works in our bodies, and the receptors basically where they work. So what we do is we've got medications such as what we call mood stabilizers or anticonvulsants. So that's medication like carbamazepine, lamotrigine, topiramate, valproic acid. Sorry, my baby woke up. All of which can help to basically stabilize our mood. Some of them we use some of them are safer in pregnancy. And I don't want anyone to feel as though, I don't want anyone to feel as though they're being given medications that are extremely dangerous. Unfortunately, we can't do a lot of testing in pregnant women. Unfortunately and fortunately. Sorry, guys.
Okay. This is actually really common for us. Perfect for this talk.
But we do know certain medications are a bit safer, and we do monitor very closely with the OBGYN, if there's a psychiatrist involved, to make sure that we're using the safest one that we know of that doesn't cross the blood barrier as much with the mother and the baby. Also keeping in mind the risks of if the mother was to stop
Oh, what a cute baby.
Sorry, Mama, sorry.
Thank you, Akia. I'll give you a moment break so that you can baby.
While we're giving a moment, I wanted to comment on something. Sorry. I wanted to comment on something about the medications. Can you hear me?
Yeah, go ahead.
Oh, okay. So, as she said, you know, you get the question, and I'm glad that the whole of medicine has come along, you know, early, maybe 15 years ago, it wasn't unusual to hear someone say, oh, I got pregnant and I called my OB and they said, oh, they don't like this medication and they don't like this medication.
Oh, please, it's a psychiatrist. It's not the OBs.
No, seriously. No, seriously, I'm saying 15 years ago. Now we've all come a long way because, like you said, it's the, no, I said, like you said, it's without you being healthy, your baby, the pregnancy can't go on. And I want to highlight something else she said, that as soon as the person is pregnant, they said, oh, can I have just little doses of medications? Since now you have a large fluid, the medications are now sort of dilute. So you actually are having less concentration. The other thing that Debbie said—
Please, hold on, Kankam. Let me just translate that to everybody.
Okay.
She's saying that the medication doses may not be enough because actually your blood processes it faster. You have lower levels of it in your blood. So you might actually need higher doses of the medication when you're pregnant. Okay, go ahead.
Okay. And then something else that Debbie said, that's true, that some medications that are known to have a higher risk, you change. The problem is you don't know whether the one that is supposed to be safer will work for you. So that's also something that we come across. We certainly want to change to a medication group that is not known to cause a problem, but some people end up, you know, in the hospital because that medication didn't work for them. So what we're saying is definitely we're weighing the risk and the benefits of medications. And hers got changed, and she'll be the first to say, like she said, she was, you know, she was still struggling. The other thing is about culture. You know, I keep hearing her say, you know, I wasn't married. I'm not sure that that would have been a big deal here in the US, you know, that you're not married.
It's a big deal here, Pat.
Excuse me?
Big deal here. It's not as much, but it's definitely,
you know, but you know, places where, so not only was she dealing with pregnancy, all this, she's also dealing with the culture that looks, you know, so again, let's hopefully someone out there who is the one who is doing the looking and the whispering, please, let's be aware of this. Go ahead, I just wanted to add.
Very important. Gloria and Caroline, I think you guys had similar experiences in the past. Someone told a story about a teenager getting pregnant.
Well, I will touch on what Debbie said about being ashamed going to church. I'm thinking Africa, like I would say, Africa, we are too spiritual. We are
please be careful.
Some of us are hypocrites in the sense that, yeah, in the sense that we go to church. Why do we even go to church? Here is somebody who is going through a lot, who is coming to God. We say the building is a temple, that we are going to consult God, we are going to get help, we are going to pray, so God will forgive our sins. In the Bible, it says, like we are all sinners, we should go to church. What? For God to what? Forgive our sins. But here's the case, I'm coming to church and people around me are looking at me, talking about me. How can I come to church? How can I be there? You understand? So the society that we are in, we have to change our mind. We have to change our behavior so that if you are going through something, we can open up and talk to you guys and talk to people. You understand? Especially she was afraid to, maybe she was afraid to talk to the pastor, because pastor is so holy that we cannot talk to them. That they will say, oh, you have been bewitched. You are what? Spiritually, something is going on. We need to fast. We need to pray for you. So on this, I will urge all pastors, all spiritual persons to come out and advocate for those who are going through these illnesses. They should advocate for them. They should, though they should pray, they should let them go and seek for medical help first before praying and fasting, because you cannot be on this medication and be fasting. You cannot be on this medication and come to all-night service. They need to sleep. They need to have their hours of sleep, because when they take this medication, they need to sleep. That is my nursing aspect. They need to sleep, eat well, hydrated, and sleep. Though they pray, God listens to all of us. We are all sinners. So God listens to all of us. They need to eat, they need to sleep, they need to be well looked after. Then I'll come to the family. The family has to be very supportive in this sense that I can find one person that I trust so much that will listen to me. We have to have a listening ears to these people, to these teenagers, to our family. You understand? If something is going on, we have to have that eye that will let you know that, oh, something didn't go on well with this person, or how was your day going, or how was your job, how was work. We should open to our families. We should be that opening eye that will listen and also see that there's something going on. Then you can help the person to seek for medical help. You understand? Don't say, oh, you know, this is spiritual, let's go to church. Fine, there's God. That's why God gave us doctors, nurses, everybody in their field, so that we can all work together. But if the person is going through mental illness or mental disorder, and you tell the person, let's go to church, fine. After church, what? After church, what? The person becomes depressed, and sometimes they commit suicide, and away they go. Then I'll come to friends. If something is going on because of stigmatization, we shouldn't spread, because it spread like wildfire. By the time you realize this friend no, this friend no, this friend no, that is not a friend. A friend look for it, like we look after each other. We help each other. So as a friend, if the person has consulted you and trusted you and shared some confidential stuff, you should also keep it confidential and help the person. Even if you cannot help the person, refer the person to somebody who knows, who can help. You understand? The person who knows and who can help, and not somebody who will go and sit somewhere and also keep on spreading it. And also to our teachers. If we are teenagers and we are in school, and maybe you find out that the person is pregnant, maybe after vacation the person is pregnant, or the person is going through a lot at home, come back from home, those who are in boarding school and all that. I went to boarding school, I know what is going on. Start talking to some of the colleagues, that will spread the news more. So the teachers should come together. They have an association, they have committee. They should come together and invite the person who is going through that disorder or illness, and talk to the person, then seek for medical help. Then we have support groups that will also come in and help. With what I'm seeing from Debbie, I don't know whether she had family support. I didn't hear her saying about mother, father, maybe sister, sibling. I didn't hear anything. But the family has to come in and help, especially if the person is a teenager not working. As mothers and fathers, especially mothers are closer to us as we get pregnant or something is going on with us as daughters. Mothers become more closer to them. As mothers, we should encourage them. We should support them. Not that the person has going to have, sex without protection and is pregnant. But the thing has that. What is the way forward? You see, we should manage the person. Maybe he doesn't want the father even to hear. What are we doing? You, in a nice way, will talk to the father about the whole thing, but in a nice way, so that the father will not approach the daughter in a different way. Because daughters will love our fathers. And if something goes on wrong and the mother doesn't take the necessary step to talk to the father about it, it has a big impact on the daughter or the girl. You understand? So mothers should also support, not in a negative way, but a positive way, and talk to the girls so that they will what? Grow up to help the community. Thank you.
So, hey, Gloria, you have opened a can of worms, eh? Very important points that you have made. There were some comments that were made while you were speaking. People were saying maybe Ghanaians are more religious. You meant to say religious and not spiritual, not the other way around. Because being religious means you are following all the doctrines, but you're not actually digesting it and living that life, as opposed to, you know, just practicing it and kind of actually looking down on people and judging people instead of helping them. You opened you brought up a lot of important points, but just to summarize, you just talked about how all the whole community can support a woman who's going through pregnancy. Because sometimes, even if you don't have a mental illness, the stress of the pregnancy, whatever circumstances are around it, can cause you to develop a mental illness. But sometimes you also come in with a mental illness and you need to be able to find the right help, the right support, even if you've made a mistake, so that you can get through it safely, because it can be a fragile state. And so we definitely thank you for the points that you raised. Those are mostly the comments. Does Amma want to make a comment about perinatal depression, or Caroline, do you have something to say?
Actually, Gloria said it all, but I will add that when the pregnant lady is going to the prenatal clinic, the partners should be encouraged to go with her so that she will know, he will know all that is going on with the pregnancy, the status of the pregnancy. I will encourage the partner to accompany.
That's a very important point. Although these days with COVID, it can be difficult to go into certain doctors' offices. And so at least in the United States, not everybody is being allowed to go in the doctor's office with their partner. But you can still put your partner on the phone, you can put them on a video call and actually help them learn some things that are going on. At the same time, you probably want some privacy sometimes, because there are things you definitely want to be able to discuss with your doctor or your midwife. And so privacy is also important. And having the space to be able to discuss that is very important. Anita, do you have anything to say about stress management and how people can cope with the stress of pregnancy?
Okay, so we know that stress comes as a result of one's perception. So you are pregnant. One, was it that you were ready for the pregnancy, or it just happened? From Debbie's story, we get to know that it was just a fling and it happened. So we can categorize her experience under unplanned pregnancy, and that comes with another level of stress, because if you are planning towards getting pregnant and you get pregnant, it means it has met your expectations. If it is otherwise, then you know that there are a lot of things you have to put in place. You have to restructure your life. You have to restructure certain things that were already existing to fit this in. And so in coping, I think like we are all advocating for, as you see your healthcare professionals, you share your experiences with them, especially in instances where pregnancies were not planned. But one thing I have realized over the time is that a lot of patients, hello,
we can hear you.
Okay, a lot of patients don't share their experiences when they go for reviews. You go and is there anything, I don't know, sometimes it's because of the hospital setting, or because they feel so overburdened and think it is not right talking to them at that point. But in coping, before one can cope best, we have to know where the stress is coming from, the source of the stress. If it is stress from your marriage, obviously, with a mental health professional around, the person can help you.
Oh, unmute yourself.
Hello.
Yes, thank you.
Okay. So it is important we know the source of the stress before we can talk about coping mechanism. Now, identifying the source of the stress, as I said, that brings about the coping. So if you know it is coming from any of the psychosocial factors that we may have discussed, then we know how to go about it. If it is taking activities one day at a time, if it is getting people coming to support you, family support, friend support, partner support, then we see how we can structure things to get you in there. If it has to do with being on medications as well as combining it with psychosocial support, we look at that too. So generally, coping in pregnancy stems from the risk factor, what is causing the stress. But basically, like the first slide Dr. Kankam shared, we know that it's our thinking and our emotions. The fact that you know you are not ready, or the fact that you are ready, but you had little expectations or extreme expectations of how things will go, contributes to stress.
You have so many questions that I want to ask. But one of the questions is, I know a little bit more about the experience in the United States, and Amma can probably also speak to that. But is there a lot of privacy? Caroline, you practiced in Ghana. Is there a lot of time to be able to talk to your midwife or your doctor about mental health issues?
Can you repeat your question, please?
Is there a lot of time? I mean, I know that, you know, we also have some OBGYNs on the line. I asked some of my friends to join from Ghana, and anyone can raise their hand and speak if they want to. But I was asking if there's time. Is there time for patients to really talk and delve into, these are the things weighing on my mind in Ghana? I know it's very busy.
Yes, now they are. Now they really are doing it. They have this individual care or focus care that is going on now in Ghana. That each patient has a midwife that she sees. So it's like when you go, you have this particular midwife that is following up with you throughout the pregnancy, unless that midwife goes on vacation. Yeah.
You opened a lot of, you brought a lot of important points. I just summarize, you just talked about how. Ikea, you went off. She did bring up a lot of important points though. So thank you, Caroline, for your insights on the practice in Ghana. Amma, do you want to say something? Because it's like, you know, she talks about pregnancy, but there's the postpartum period. There's also, you know, a little bit about screening. There's a planned and unplanned, so many things. I mean, great things, Anita. Go ahead, Amma.
Yes, so I think we have talked a lot about patients who know their diagnosis, they're on medication, they have other stressors, and they're going through pregnancy. And the other, I think, group of patients that we have are people who don't have a diagnosis, who, as far as they know until they became pregnant, they maybe had some mood changes around their period, but that was it. And in the US, like Eno said, we usually screen our patients. So at least once during the pregnancy, you will be asked some questions that are pertinent to how your mood is, how you're feeling. Are you getting enough sleep? Are you getting enough support? What are the stresses in your life? So that we can see if you maybe have some risk factors for developing a mood disorder during the pregnancy or after. When we talk about, I think we use the term postpartum depression to talk about depression that we discover in pregnancy or after pregnancy. And it's usually actually for the 12 months after you deliver, you could develop this diagnosis at any point during that time. And so as doctors, nurses, midwives, pediatricians, primary care doctors taking care of a new mother, this is something that we should have on our radar in terms of making sure that we're asking questions. And I'm really glad that Anita is here, because she's highlighting for us in Ghana that we have a huge gap in terms of what is the tools that we can use to ask our mothers, to screen our mothers, to see if maybe they could be at risk. And so we should be watching them more closely. We should be making sure they have the support they need in order to get through the pregnancy and also to get through the period, the first year after the pregnancy. So I think one of the things that we heard about was Debbie's symptoms that she had before she was diagnosed. What if you are someone who never had any symptoms and now you're pregnant and you're in the middle of your pregnancy? How do you know that you have a mood disorder? I think is something that someone may be wondering. Or if everybody who's had a child before, the first month you don't sleep, right? Because you're waking up every hour to feed the baby. Sometimes the babies cry all the time. It's stressful. You're not able to eat because you're, unless someone is force feeding you, your every moment and attention is on this baby. And so sometimes the mother herself will not even recognize that something is wrong because she's just focused on making sure this baby is okay and not thinking about herself. And this is why what Miss Gloria and Miss Caroline said is so important. The family around her is so important. They are the ones who will notice that she's not like herself. Yes, she just had a new baby, but this is different. Something is not right. And they can bring it to her attention. They can bring it to the attention of the midwives, nurses, and doctors who are taking care of her so that she can get the help she needs. So before I stop talking and have other panelists join in here, I wanted to just distinguish between the symptoms you can have and what they mean. So like I said, the first few days after you deliver, it's very overwhelming. You're not getting enough sleep. You may be in pain from the actual delivery itself. If they had to do a C-section, if they had to do an episiotomy or a cut to let the baby come out, you're healing from that and you're in pain. You're not able to go about all the normal activities. And so you can feel very emotional. You cry easily. You have trouble sleeping. Even when the baby's asleep, you can't sleep because you're just so wired. That we call postpartum blues. It lasts for a few days to maybe a week or two at the most, but it will go away. It's not permanent. When we start to worry about maybe this is postpartum depression is when it's usually 2 to 3 weeks after the delivery. You're having these issues, ongoing issues with not being able to sleep, with being very emotional. Your mood is all over the place, crying for no good reason. Sometimes you even start to have thoughts that are not safe, or have bad feelings towards your baby, because you feel like you're doing everything for them, but like nothing is enough. And in your sleep-deprived mind, it might be hard for you to know that something is wrong. You're just like, I just can't figure this out. But maybe your husband or your partner or your sister or your brother or your mother and somebody in the house can be like, okay, it's not normal for you to be acting this way. So let's figure out what it is. If you have postpartum depression, telling somebody who's taking care of you is important. Your pharmacist and your OB can even start you on a medication, but usually we would refer you to our psychiatry colleagues and have them start you on the appropriate medication. The medication may take a few weeks to actually be very effective for you, but they'll walk you through it and you will not be alone in that experience. And so I think being able to know what to expect, right? Not every woman will have this experience, but some women can. And having other people around you who know and are educated to be able to recognize those signs is very, very important. The last thing I would say is, for a lot of women, sometimes the resistance is coming from, I don't want to be on this medication for the rest of my life. And I think we mentioned this before. Nobody knows how any of our lives will unfold. But for the most part, with postpartum blues and postpartum depression, with the appropriate management and treatment, it will resolve eventually. And so you may not necessarily be on that medication for the rest of your life. In addition to medications, the other thing that we talked about is actually you can just sometimes need somebody to talk to. You have a lot of stress in your life for whatever reason, financial, emotional, mental, family, partner dynamics. It could be anything. And so parts of that treatment could be just talk therapy, just having an ear, somebody who doesn't know you, there's no judgment, and they can talk to you and help you think through a few things, whether you've delivered already or you're still pregnant. And so I just wanted us to also include in our discussion moms who've never encountered mental health issues, and so they may be slow to recognize it. And the importance of them having people around them who can help to figure out that maybe something is wrong, and then for them to be able to get the help they need and not think that it makes them permanently a mental health patient.
A lot of good points. Thank you so much. You touched on some of Gloria's points before about the fact that people who have mental health conditions can be functional members of the society, especially if they get the help that they need. And so all family members need to be involved. And you touched on somewhat of an important point. So the partners, if the wife is talking a lot, how should they handle it? How are these men? They're also going through things. So anybody want to speak on the guys? We are talking about the support that they can give. Can we touch on some of the support? Like if your wife is talking a lot, if you notice a change in behavior, things like that, instead of being bothered by it, or so can we touch on it a little bit? Gloria,
before we get to the guys, can I just touch on a couple of things?
I do want to touch on that. And then there was a I also want to ask Debbie about medication, if there was any point she started medications, and if that affected her in any way as well. So that's something that's coming for Debbie. Go ahead, doctor.
Okay. That we know, studies show that only a fraction of those of people who have these mood illnesses have a label. And some of us have only worked in the US. It's when it comes to mental health, the US not too different from developing countries when it comes to mental health. Most of my referrals are from postpartum, okay? They are referred after postpartum. But I will tell you over 50%, if you ask, the question will be what Debbie went through. So the first thing is, I think someone said, make sure you tell your nurse, you tell this. Being aware that there is this stigma, we in the health field, not just the mental health, all health professionals should be proactive. Don't wait for the patient to ask you. Make it easy. What about your life? What's going on? Most mental health illnesses have a hereditary basis like diabetes, So let's be the one to ask, because it's going to be difficult. Even our culture itself makes you talking to the doctor is almost like a no-no, let alone telling them things that you think they don't want to know. So we have to do that. And then awareness, even with stigma, awareness programs like this, as people get to know, okay, then it becomes a little easier. Also, what I showed, because most of the changes are in the thoughts and in the feelings, by the time anybody sees, it's a little late. So my message is, know when your thoughts start changing, when you have the feeling, be the one to empower yourself. You are worth it. I say you are worth getting, you know, if you have, you know, infection, you're going to get help. You are worth getting help so that this doesn't interfere with your life. So that's, and we know that the highest risk for postpartum depression is depression in pregnancy, and the depression, history of depression will put you at more risk. So we have to do the asking. And no, not just, do you have depression? People don't know. Let's ask the symptoms. So we have to, you know, that's what I wanted to say. And in terms of, will it go away? There is no need to batter it around. Mood illnesses are part of illnesses that people know. Everybody knows. Most people know that if you have diabetes, it's not going away. High blood pressure is not going away. Asthma is not going away. But you don't have the flare-up every day. So let's discuss it, because people do ask, doctor, I don't want to be on this medication for the rest of my, won't it go away? We don't have cure, but you want to limit the bouts so that it doesn't affect your life. So again, it's the exchange. The men, yes, we need the men because you need the support. You know what, when my patients bring their spouses or, well, pre-corona, they get extra hugs from me. And I tell them virtually they have a piece of my certificate because they are part of the team. So it's important in our culture. I grew up in Ghana. We don't, the culture doesn't allow the men. It's like you are weak if you are coming. When I was in doing a medical student, if a woman is coming to have a baby and the man is, you know, around the corner somewhere, what's wrong with you? Why are you here? Go home. So things have changed. Let's include the men. If we do that, you know, that will be helpful. So.
Thank you. Thank you so much, Dr. Kankam. I think some of the things you talking about, people talking to their doctors, made me think of some of the reasons why women can have depression or can have mood disorders. And so I thought of people who have miscarriages. We can't really exclude them from this conversation. It's not just when you have a baby that you can have a mood disorder. And it doesn't, just one can lead you to have a mood disorder. And so that is something we need to keep in mind. People who lose a baby after birth, just keeping that in mind, that that can also cause depression. We mentioned earlier stresses in pregnancy. Oh, you should have had a boy, not a girl. You should have had a girl, not a boy. Cultural things, you are from here, you are not from there. Some people stress about the men they get pregnant with. You know, maybe they don't know who the partner is. All these are things that can definitely cause issues. Debbie, I'm going to come to you, but I do want to get to some of the comments from the audience, and we only have 20 minutes left. But when Gloria was speaking, somebody said, thank you, Nanama Dumabwache. She said, thanks for touching on the cultural aspects. Pregnant women need support no matter the circumstances surrounding the pregnancy. Also, as a society, we also need to look at the public health, primary health prevention aspects and work to prevent adverse childhood experiences, which we know are a major risk factor for mental illness. And actually, that's what, when you were talking about some of the circumstances, it's like rape. You know, if you were raped, for instance, and sometimes you are actually in a relationship with the person and they rape you, that can cause mental illness. So being able to talk about it, being able to talk about your childhood, open up, find help, that can all really help. Thank you so much, Nanama. And then Dr. Palcote said, preconception counseling is important for all women in general and women with medical problems on medications. So if at all possible, I guess planning for pregnancy, you know, so if you know you're going to get pregnant, getting on a different medication that's supposedly safe, but as we learn, sometimes the safe ones don't always work. So weighing the risks and the benefits are very important. Thank you so much, Dr. Pearl. And then Feed the Sick Foundation said, in Ghana, it's very difficult for patients to talk about their mental illness. The stigma is very great here. Thank you so much for highlighting that. We are very well aware. I think it's even great here, especially in certain communities and communities of color, you know, our Hispanic populations and things like that, and even the general population in general. It's very, very tough. Mental health has a stigma, but it's changing. And if we keep addressing it, we will change it. Gloria's iPhone said, yes, Ghana focused and individualized ANC and postnatal services. We are increasingly improving mental health awareness, but need to develop and train on screening and management of mental health issues in maternity, adolescent health, and development, and for the aged. Very educative. Thank you all. All right, there's some more comments, but I'll let Debbie speak if she could on, was there any points in your, you talked about breastfeeding at the time you were on medication and you were very drowsy, and I don't know how you dealt with the sleep deprivation in the postpartum period. And also, was there any points when you stopped taking your medications? And then you talked about living in fear. And I mean, I know that in the COVID era, a lot of people are living in fear. I mean, we've all gotten a little bit more used to COVID. I don't know if anybody later on wants to make a comment about dealing with fear, living in fear, how to conquer fear, how to address it, and what to do about it. So if Debbie wants to speak out, I'd love that.
Okay, so about breastfeeding and being drowsy, the help I got. Well, I'm grateful to God that I have a very adorable mother, and she's a nurse manager at the GPSF Hospital in the Ashanti region here in Ghana. So she being a nurse, she has a lot of insight on mental health, on being a mother, both from she being a mother on her own and she being in the health field. So when I'm breastfeeding and I'm drowsy or I'm asleep, sometimes baby cries and I'm so much in slumber. So she takes my nipple and then feeds baby. I will be fast asleep. And then I do with my mom actually can be busy sometimes, and she might not be at home during the week. She comes on week. Feed baby. Sometimes I have to give her. I don't take. Always try to set.
Okay, go ahead, Debbie. Thank you.
I try to set an alarm to wake up when it comes to even giving medications to baby when she's not well, but the alarms don't wake me up. So I have to skip the medication. It's not I have to anyway. There's a way I can go around them. I'm still discussing it with my doctor. So that's for the breastfeeding and all that. And with the fear, even before, you see, the thing about this COVID-19 is that I've always been in quarantine. Then the stable me doesn't like to go out. So I'm always indoors. And for new mothers too, you always have to stay indoors and because you have to shield baby from a whole lot of things. And even with this coronavirus too, babies are not advised to be in public. And for you, the mother too, since you can get the virus and give it to your baby, you're also advised to stay indoors as much as you can. But if it's fear of the COVID-19, I don't really have any fear. I just have to observe protocol. But fear with how people, I have a big issue with how people see me. So fear of how people see me with a baby and all, having a baby is a glorious thing. It's a beautiful thing. But sometimes when you don't plan it, you have people looking at you in a different way. Okay, so she had sex, is there, and so she's pregnant now and she has a baby, and fear of getting a good job. Sometimes when you want to get a job and they start asking you questions about these things, you don't really know how to put it across. And if you have this, your incoming boys wanting to sleep with you because he feels you're a loose girl and you've had sex and you sleep around, and so you feel uncomfortable. I've tried to get a job, but I've had all
But does
these things
everybody know?
coming
How
up.
does everybody know this?
It's not easy.
No.
How does everybody know what? I beg your
Does
pardon?
everybody know that you have a baby? Like, is that some of that information private? If you're going to get a job, do they know? How do they know you have a baby? If they don't know you.
Well, I have to bring my dad in this. So I usually do those things with the support of my dad. And with my dad, he says that you have to come out clean with everything, because if you hide it and then tomorrow maybe baby is not feeling well or there's an emergency with baby, you're now going to have to come and explain to your boss that, okay, so I have a baby and I have to attend to baby. So it's even in my CV that I have a baby. Is that information is actually there, because that's the advice my dad gave me.
Okay, that's very good advice. But how the baby came about and whether you have a husband or not, how do they find that stuff out? Or do they ask?
Of course, they ask. But with all the jobs that I've tried to get, they do ask. They do ask because, you know, if you are married, most often than not, you should have a band or a ring on your hand. And sometimes when you're going to an interview, they look at all these things. So you have a baby in your CV, but you don't have a ring on your hand. So are you married? Something like that.
Wow, that is interesting. That is definitely very different from the US. Some people even just wear a ring and go to these interviews, but who knows?
Well, I wouldn't be able to do that. I like to be very frank and Francisca about everything about me. So if I'm not married, I wouldn't wear a ring on my hand, especially on the ring finger on my left hand. I wouldn't do that.
Okay. But has it helped, being honest and everything, has it worked out? You found a good job and found them to...
Well, I'm still currently unemployed. But I have some few plans. I'm working on it. I want to go into the music industry, so I've gotten a producer, but he's quite busy at this point in time. So when I get all that, I'm going to start. I'll go into music, but I would want to be in formal employment so that I can save money and then get to go back to school. So until then, maybe I'll have to concentrate on the music and see how much it will fetch for me, and then I can go back to school.
Wonderful. Thank you for sharing.
May I comment on something, please?
Yes, Dr. Kankam.
Yes. This is so important. You know, like I said, I've known Debbie. We physicians have to be a little proactive. We're not talking, we have had a conversation, Debbie and Nick, recently. Sometimes the medication, the doses that make someone can take whatever she's taking is okay for one person, another person may be drowsy. We assume that our patients know that, of course, if you are drowsy, just let me know. No, they don't. So here she is telling us that her medication, she'll be breastfeeding and she's fast asleep. The baby could roll over. Okay, so when we give medications, let's tell the patients, you know, if there are colleagues out there, all of us remembering this, if you have ABC, let's know, because we can adjust the dosing, okay? Her story is not uncommon. And like I said, and I work in the US, not Ghana, okay? People will be almost fired from work thinking they are on drugs, and it's the medicine we are giving them. So we need to have more discussion that there can be adjustments. Two, the fear and all that we're saying. Even here in the US, it took some time to have some laws, some that you cannot ask a prospective candidate about their personal life. It used to be the same. People make judgments, but now it's against the law to ask about, you know, marriage, children. So these are some of the things. Yeah, it's not too long ago that you could ask those questions. So that's one. And the other thing about skipping, medications. We can always, take your medication every day. One of the studies show that one of the highest factors to non-compliance is side effects. So we have to not just preach, but explore why patients are, they miss their medication. I just wanted to highlight that. Thank you.
Can I just tag on to the end of that? With
Yes,
regards
go
to
ahead. Thank you so much, Akia.
with medication compliance. So Dr. Kankam is absolutely right. A lot of the time we see patients that, it is because of side effects. And I know that pharmacy practice in Ghana is very different from my practice in Canada. And I believe practice in the States, if there's any pharmacists listening today. But I know that even with myself, with my patients, because the stigma still exists with mental health, even if somebody comes in and they're interested in getting pregnant, rather than asking, are you depressed or do you have some signs and symptoms? We ask them, how is your eating? How is your sleeping? So just asking them specific things that will trigger them to say, you know what, I actually haven't been sleeping. Or if it is medication related, asking early and asking frequently, are you finding this makes you drowsy? Have you noticed you're eating more? And just monitoring them frequently with every interaction. I think the pharmacist has a bit of a unique position where we're always available. You don't have to make an appointment to come and see us. And a lot of patients sometimes too feel a bit more comfortable knowing that I am just a person standing around in a store or in the hospital walking by, that they can just come and say, I've noticed that my mouth is dry all the time, or I noticed I'm drinking a lot, whatever it may be. So and the pharmacist is also another resource as far as asking these questions with side effects, and we too can ask just to see if there's anything that can be done with the medication. And I did want to go back, I'm not speaking on religious or spirituality, but when it comes to fasting, because I know that we have, where I live, there's a huge Muslim population, and we have a lot of patients that do observe Ramadan. And there are ways, once a patient is stable, if fasting is very important to them, that we're able to manage and work with them. I know a lot of pharmacists, including myself, have developed protocols to assist patients because, like Dr. Arnold was saying, we're holistic in our approaches, right? So we've got our medication piece, we've got talk therapy, we do have spirituality, mindfulness, whatever it is that makes one person feel whole. So finding ways to support them. And so if fasting is something that's important to them, even on medication, we can support them through that.
Thank you very much for that. And I'm glad that you talked about the holistic approach to taking care of the whole human, and also trying to meet their specific needs. So somebody really wants to be able to fast and pray and do all these things, finding ways to help them to do that. That's wonderful. We only have a few minutes left. So I wanted to see if maybe Ms. Caroline wanted to talk a little bit about living in fear and how pregnant women could manage living in fear. If that's something that Ms. Anita wants to talk about. And then all of us to go out with one message, our closing message, until we end the session.
So I would say that if the patient knows what triggers the depression and anxiety, the fear, they should open up to family, or the midwife, to prevent them having that feeling. They should open up, exactly. So we can also refer them to a counselor or a psychologist, to get advice.
Thank you so much. Anita, is there anything you want to talk about in regards to living with fear? Because that was something that stood out to me when Debbie was talking. Just that she was afraid that her medication may not work. That was the thing that she was worried about. But there are so many things that people are worried about with pregnancy. Some people are worried about something happening to the baby. And are these normal fears, Dr. Kankam and Amma? Are these, so there are so many things that people can be afraid of. People can be afraid of their partners, intimate partner violence. So you're right. What is causing the fear, Ms. Caroline? And then opening up and talking about it. Anita, to you.
Exactly. So like Ms. Caroline said, there are some times you know what is causing the fear, but there are other instances you, the patient or client, do not know what is causing the fear. That's when we have the generalized anxiety, where you don't know the source of the fear. And like you are saying, I've encountered a pregnant woman who thought she was going to give birth with baby with 4 fingers. Initially, I thought they were wild imaginations where you can be pregnant and everything you're thinking about is giving birth to a deformed baby. But I realized that in instances where they don't know where the source of fear is coming from, you, the healthcare professional, have to go the extra mile. And as we are educating all of us and advocating for in-depth mental health issues, I think that when people approach us, especially as healthcare professionals, with generalized fear, we should help them narrow it down so that we identify the source. It will come, but it also has to do with our cognition, how we are perceiving things, how we are thinking about things. So if you are happy, it happens that a patient comes out clearly to you to bring out all her fears, and especially in instances where they do not know the source of fears, you have to go the extra mile to help them identify the fear and walk the person through it.
Okay, thank you. Now we have 3 minutes left. So I would like everybody to go through our panelists. Thank you all so much for dedicating your time to talk about this very important topic. There are actually so many things we didn't even get to. We didn't get to talk about nutrition. We didn't get to talk about so many things, even breastfeeding at depth and how that can be a stressor on its own. There are also other comments from the audience that I did want to talk about. The Dr. Gloria that I mentioned was Dr. Gloria Kwansa Asare, who was the Deputy Director of General Ghana Health Service. She's retired, but she's the one who was giving us some of the nice comments. She mentioned the need to support from partners and family systems, especially in-laws, is very important. They usually mean well, but need to be part of a dialogue on what is recommended by health partners so they can support. I'm a public health physician, recently retired from the Ghana Health Service as Deputy Director General and Director of Family Health Division. We encourage and include men in MCH and have innovations such as pregnancy schools and other services. So that goes to Dr. Kankam's comment about just being involved. And I think Caroline and Ms. Gloria also being involved with the patient's care. There's a comment from Lillian saying education begins from admission to discharge and even pre-pregnancy, as Dr. Pearl said earlier. It's up to us healthcare professionals to educate our patients on the importance of sharing their health issues. All Dr. Kankam is advocating is educating our patients. And that is where everybody comes in, including everybody, even from janitorial staff, all the way to pharmacists, physicians, nurses, and everything. So please give us a parting message. We have 1 minute, but we'll go over, and please give us a parting message. I do thank all our panelists. Thank you so much for giving us your time, sharing your knowledge, sharing your expertise. I thank all the attendees, people from GPSF, people from NAGNF, people from the Ghana Pharmacists Association, and all our friends on Facebook and elsewhere who joined us today. We are grateful. This is a very important conversation. We will continue it another day if there is interest and more specific questions. You can go on ghanaphysicians.org and send us questions, comments, requests, and we will come back to you next month with another episode. So I will start. Debbie, do you have any, or Dr. Kankam, you can start.
My parting message is the reason that we say mood disorder is not just depression alone. You can have any of those 4 moods that I discussed. Any of them there can be a flare-up. So we're talking about anxiety. People can have fears, and it's not because of any specific thing. There's also the other side. Oh, you must be afraid. It must be a reason. There may not be a reason where they have fears that they call the irrational fears. So there can be severe anger, depression, anxiety, all of it. So again, it's exploring.
Hey, can happiness, too much happiness be bad?
Debbie told us that at 21, the reason why she went for treatment is because it's not about the happy, it's where there's no risk. Remember when there is no balance, she said she was a nuisance. That's where. So anything that is outside of our norm, it's not good or bad. It's outside of our health normal. Just like blood pressure outside of norm is a problem. Sugar range outside of norm is a problem. So we're talking about health, not good or bad.
Thank you. Debbie, you, please.
I want to thank all of the panelists and the audience for giving me this wonderful opportunity. I always wanted to talk and be a chatterbox, but I've not had this opportunity with all you wonderful people, big people, great people. Well, my closing remarks is that mental health can happen to anybody. It is not limited to just one person. It can happen to the rich, poor, the old, the young. It can even happen to head of states, everybody. So we shouldn't stigmatize. We shouldn't look down on anybody. And to all patients, we should get all the help we can get. Don't feel embarrassed to talk about your issue. Talk to your doctor. Let your doctor know. Remember that your doctor is also learning from you as much as you are getting the help you need from your doctor. With your friends and loved ones, let them, especially your inner circle, let them know that this is who you are, so that when you have a relapse or you are in a deplorable state, they can help you before you actually get to the hospital. And also to all expectant mothers and nursing mothers, those with mental health conditions, those without, I want to encourage you that you are bringing a new life into this world and you have a life in your hand. Handle it with care and love and all the good things in this world. And that's it. Thank you so much.
You're the sweetest. Debbie, thank you so much. You are definitely right. Doctors do learn from their patients. We want to hear from you. We call it a practice of medicine, and we are always learning people's motivations. We are learning influences. What makes you make the decisions you are making? How can we help you better so that we can help other people better? So she is so right. Thank you so much for your courage. Thank you for sharing your story. We admire you. I really think you should start a blog and become world famous. And you don't know how many lives you can touch, but there is really life out there, and the world is your oyster. I really appreciate you. Miss Caroline, you're next. Any message for us? I think you're on mute, my love.
Okay. Yeah, so I will encourage the pregnant ladies who have, history of depression and anxiety, others to avoid triggers. They should attend to their clinics as scheduled, be on that balanced diet, and report any unusual symptoms that they feel. Yeah, thank you.
Thank you so much. That is very important, avoiding your triggers. We didn't talk a lot about this, but in the US, we do deal a lot with drug dependence and things like that. Those are, or alcohol dependence. That can be something that's in Ghana as well. Triggers can go from, hunger, just being sad and all other things, and trying to avoid it, making sure you get care, making sure that you see your doctors. Okay, Ms. Gloria, you're next.
Oh, okay. What I would love to say is that to our partners, you should know that we are there because of you, and we need your support in times like this. be that we are pregnant or we have delivered or we are breastfeeding, we need your support every time. And fathers or spouses should know that as we are breastfeeding, there are sometimes we go through C-section or a lot of trauma during the delivery. And at that time of breastfeeding or postpartum period, we need their help, especially our spouses. Though your mother will be there helping you or your aunt will be there helping you, your spouse is always in the room. We know that as we have fresh babies, you are afraid of the babies. They are really afraid to touch the babies, but we can send you. You can ask us for help. What do you want me to do for you? Be there for us. Maybe I have to take my medication. It's on the table, but I cannot get that. It's you who help me. Be there for us. Okay, with the stigmatization, sometimes it starts from the healthcare workers. Oh, leave her, she's crazy. Leave her, she's mad. Leave her, oh, she's this. So we refer to them with names. That is so belittling and also puts the person like doesn't belong to the society or doesn't belong, like the person doesn't deserve to be addressed as a human being. That is not good. We healthcare personnel should address them as human beings. We should come down to their level to help them. We should be approachable. When they come to us, we shouldn't raise ourselves like we are God. No, we should come down to their level and listen to them so that we will know what is going on in their various houses, their various homes or various places that maybe it's workplace that they have the problem. It's not even from the house. So healthcare workers, we should come down to their level and help. And also to religious groups, we should also come down and help these people. We need their help. Ghana, especially my homeland Ghana, we need your help. Advocate more for mental illnesses, mental disorder, mental health. We need their help. They focus more on physical health, but not mental health. Please, we need your help with mental illnesses. Thank you.
Thank you so very much, Gloria. All right, Ms. Akia, do you want to go?
Sure. So I have a few points that I'm going to summarize in 30 seconds so we don't go that much over time. The first thing I'd like to say is thank you for organizing and bringing all of us together to discuss this. It is extremely important as we're all extremely passionate and we all know the importance of mental health and how we're not just a body without a head basically existing. So thank you for bringing us all together to discuss this. I wanted to highlight that for everybody, just the fact that we're all on the spectrum of mental health. And at any point in time, as women, any of us can get pregnant, have a baby, lose a loved one, lose a job, get sick, all of these things. And we can all move anywhere on the spectrum. So it's not unique, as Deborah was saying, to any one type of person or to any age group or race or gender, anything. So it's really important just to remember that and sort of helps us to normalize mental health. It's not a flaw, it's not a sign of weakness, because I think that sometimes, especially as Ghanaian women, we try and hold everything and appear strong and to, try and hold everything together. So if anyone asks you anything, you don't even want to say how you're feeling necessarily. So it's not a sign of weakness if you're feeling tired or if you're feeling any of these things. So just to remember that none of us are alone. Nobody's alone in anything, and there are supports out there, and we can also lean into our partners being educated, our families as well, to get the support that we need. And as far as pharmacies, just as far the fact that medications, they do help, and there are, if something may not be working, there are other things that we can do, number one, and that if someone is on medication, that does not mean if you have a dream or a desire to have a family, that it's not possible. With your team, an individualized plan can be made that will help you to achieve what it is that you want to achieve in the best way possible, keeping you healthy and keeping the baby healthy. So thank you, everybody.
Thank you. And now to Anita. Okay, I don't think we have Anita, so let's go to Amma.
Anita is talking. I think she's just muted.
Oh, I can't see her.
Okay. Anita, can you unmute yourself?
Hello.
Hi,
Okay.
Anita. Okay, thank you.
Yes, so I was saying that we have learned a lot this evening, and in as much as we have all upgraded our knowledge base, we should go more into making what we have learned practical than theorizing it. Also, I saw Dr. Gloria's question on if we could give mental health screening tips. I want us to go review the Edinburgh Postnatal Depression Screening Tool as only a 10-item.
You lost her?
You did. Okay, Amma, let's go to you and then we'll come back to Anita later.
Okay. I think what everyone has said tonight is so important and so needed. And I'm very happy that we were able to share all this information, our experiences, our professional experience and recommendations to everyone. I hope it was very helpful. I think for me, the experience is more enriched by being able to share this panel with Debbie and just seeing how courageous that she's been. And she has such a wonderful outlook, I think. And she models for all of us, you know, what living the experience of having a mood disorder, but able to participate in life is all about. In terms of the message that I would want to leave everyone with, I think no matter where you live, if you are pregnant and you're under the care of a provider, a midwife, an OB, one of the things you should know is that they should be screening you for mental health issues sometime during your pregnancy and also at your postpartum visit when you come back for your checkup because after you've delivered. So at least twice during the pregnancy and once during the pregnancy and once after you've delivered, someone should be asking you questions about how you're feeling, how you're sleeping, how you're eating, what your thoughts are. And so if that's not happening, know that that's not right and try to get help. What Dr. Kankam and everyone else has said is very true. It is our responsibility to ask those questions. It is our responsibility to do the very best by you. But I also want you to know what you should expect, which is that if someone is not asking you these questions at least once during your pregnancy, whether it's before you get pregnant or while you're pregnant, and then after you deliver, they're still not asking and concerned about how you're doing outside of the physical, something is wrong and you need to try and get that help for yourself.
Thank you so much, Amma. Anita, we have gone over by 14 minutes. I do apologize. Anita, do you have something to add? Are you back? Okay, I think we lost.
Back.
Are you back?
Yes, I could hear you. I was talking.
Go ahead.
Okay, so I was talking about practicalizing what we have learned this evening, shifting from theory, and making it more relational. Two, I saw Dr. Gloria's comments on a screening tool, and I want to see Ghana Health Service incorporate the Edinburgh Postnatal Depression Scale in the antenatal care book is a 10-item questionnaire that is self-administered and so easy to administer. And 3, there is a support group that has come up, the Psychological Relief for Women International. That women undergoing all mood disorders can reach out and receive the support they want. So now
Okay, I thought you said so something, but thank you so much for bringing that depression screening tool up. We can look it up and talk about it at a later time. Again, it's after midnight in Ghana. It's very, very late in the UK. For friends from the UK, we should end. I really thank everybody who joined us, people who made comments, our panelists, Dr. Kankam for giving the idea, Debbie for her courage, everybody who brought her expertise. I appreciate it. Next time you want to see some men on the panel. So let us know if you are interested in any topics that you want to talk about that people have questions about. And we want to work with our colleagues in the UK and in Ghana. We want to work with our nursing and our pharmacist friends. So please contact us, ghanaphysicians.org. Let us come up with some ideas about health topics for the public. And I think somebody made a comment, Ethel. Thank you so much, Debbie, for sharing your experiences. Carl said excellent points about everybody being vulnerable and becoming mentally ill. And Gloria said, thank you, Anita. Thank you so much, especially to our colleagues in Ghana. Thank you for dedicating your time. It is definitely past your bedtime. We really, really, really appreciate you. Thank you for making this so great. Thank you, everybody, for attending, and we are out. Thank you. Thank you, Amma, for finally coming. Thank you always, Dr. Kankam. Gloria. Thank
you. Bye.
Thank you, Kia. Bye-bye.
Nice meeting you all.